And without further ado, I do want to introduce our first guest. We're excited to have with us Bruce Buzzard, who is the president and CEO of Humana. So he has been one of the innovative leaders in healthcare in this country. As a trained accountant with degrees in business from Texas A&M University and the University of Houston, Bruce rose in leadership in health and medical system companies, including as CEO of McKesson Specialty U.S. Oncology. His experience led to an understanding of the gaps in our healthcare system and just how disconnected the system can be from patients' needs. As president and CEO of Humana since 2013, he set out to directly address these failings. Under his leadership, Humana has created an integrated care delivery model, lowering costs, enhancing value, and providing simple, personalized member experience. Bruce was one of the first to speak out about the importance of social determinants of health. He sought to move Humana to address both personal and community determinants by acting on his belief that to improve a person's health, you need to not only improve their physical health, but also need to improve how they live, work, play, and learn. Sorry, wrong order, but close enough. Humana is dedicated to improving the health of communities it serves to make it easier for people to achieve their health goals. They're leading the way in measuring members' health by the number of healthy days, as defined by the CDC, that includes outcomes based on an individual's health, well-being, and quality of life, and has shown impressive results. Through his leadership, Humana is transforming the way care is delivered by eliminating barriers to care, enhancing the consumer experience, and bringing care back into people's homes. Humana is doing much of this by leveraging the flexibility of Medicare Advantage's payment structure to create bridges for older adults to improve their health, their lifestyle, and their quality of life. We just had breakfast together. I think we're going to have a really good conversation. So please join me in welcoming President and CEO of Humana, Bruce Buzzard. We actually do a quiz for our beneficiaries. I'll call it, we just finished Academy Month with our beneficiaries. And I was concerned that some of the questions were a little bit tough for maybe even this crowd to answer, but they did pretty well, which is great.
That's great.
So let's get started. I did want to just tell the audience that if you do have questions, there should be cards on your table. You can fill out the card, and we have a staff or two will come around and collect them, and then they'll hand it to me. So we'll try to have get some questions in. But let me start off. The theme of this summit is in innovations. And so before we get into maybe some of the specifics about what Humana is creating, maybe a more global question. Given the degree of change happening in healthcare today, particularly in Medicare Advantage, the drive to value in particular, and the focus on social determinants, would you share your perspective on what is needed to move the industry, how you're doing this, but how to move both payers and providers to evolve and to promote change and to innovate? Let's start there.
There's a lot there to that question.
There is. So you can answer it any way you like.
I might be talking for a while. I think a few things that I do want to first lay out is the conversation that's happening, whether you talk about Medicare for All or other reimbursement, is around the ability for coverage. And I think what Medicare Advantage offers is the ability for us to take coverage, innovation, cost and quality together, and I've just seen it over the years in the growth of within Medicare Advantage overall. I think as you talk about and give this general question about what's going on in the industry, I think there's a number of things that I get excited about. One is there is a change going on in the industry and moving to disease progression, managing disease progression. And I find that the ability to impact disease progression is an exciting time with the tools that I think are evolving. You were mentioning the technology tools that are evolving. I'm very excited about interoperability. Mm-hmm. I think the ability to see up and down the healthcare system and being able to do that in a way that you know what's going on both inside the healthcare system but also outside and being able to share that. I do believe that the ability for us to continue to evolve the care model and to encourage and help providers take risk. And being able to use information analytics. And I look at it as our responsibility as an organization to assist that and being able to provide them the information. So to not get into a lot of details of your question because there's so much to it, I think technology advancement, I think the ability for us as an industry to evolve our information and velocity flow. I think the ability to continue to be partnering with providers on a value-based payment models to be able to evolve them in whatever nature they want to do are all good examples of that. And within that, there's a lot of details, but those would be the major areas.
Yeah. So just to follow up on that is it really is this whole move away from fee-for-service into a different payment model.
Yeah.
I think that's sometimes hard to talk about, and not this audience, they'll know about it necessarily, but sort of more publicly in a way.
Yeah.
Some of that is sort of invisible to the patient in a way until they start to see more coordinated care. Could you talk a bit more about how plans are helping to move providers? Risk-based is something you talked about, but to really get that movement happening, to share that data, how is that actually playing out?
Yeah, I think a few things. I think first, the motivation of the provider varies. I think we see in certain provider, both in markets and in provider business models, to see that variation. So we find that providers that have a lot of fixed assets are less oriented to value-based payment models and more oriented to the traditional fee-for-service. That's not a generic statement, but we just find that is an area. So the second, we find that in providers that are looking, that have a younger provider base, that are more longer term, we find them to be much more motivated to make that involvement. We also find that the area, especially in the primary care area, where they traditionally have made less than the specialists, have been more oriented to the value-based side. So that's just sort of where the motivation is. What we do find is the more we can put it in their workflow, and being able for them to be able to understand the next best step is a very, very important part of that. And I know there's a number of organizations that have done that well inside their area. I get back to interoperability, feel that with more interoperability, we're going to be able to drop that information in there. For us as an organization, we also provide human resource support. So we have about 600 people that assist providers in being able to take that risk.
Because it's a real change for providers.
It is. It is. And it's day-to-day decisions.
Yeah.
It's day-to-day decisions.
So you have to make it actionable for them.
That's right.
Yeah.
And all the way down to this gap you need to close. But the last thing is the degree of risk people want to take. And so you have full risk, and there's 30-some% of our members are in full risk relationships, and that is sort of a much more sophisticated model. But there's people that or organizations that we will contract with and give them just upside risk, so we'll pay them for quality and cost. And so the ability to veer the payment model according to the risk tolerance of the provider is an important part of that. So it's technology, it's human resource, it's the ability to also then for payment model to be able to help
shift their mindset on all of it.
But at full risk, asking somebody to take full risk is ridiculous. I think you have to assist them in that.
In that, it's
but they have to be motivated. Just another side, we would reward our people. We would measure how many of our members would be in risk, some type of risk contract. And what we found is some would say, I want to take risk, but they never had the heart to do it. Because they had the business model that they just didn't want to do it. And we finally really not only said this is the payment model, but are you really motivated? And went through some conversation about that.
Yeah. Well, it is, again, as we say, really a very different structure in terms of what they're accountable for, and
yes.
people who work with changes things for them. We're going to hear from some provider panels later. They're going to talk a good bit about this as well. One of the other things that we know is happening, I'd love you to talk about, is that we are seeing a lower cost for beneficiaries. We just did asked someone to do a report. It'll be in one of the breakouts about this, and does show that beneficiaries in Medicare Advantage, particularly from low and modest income beneficiaries who are actually the majority of people in Medicare Advantage, they're really finding it a lower cost burden. It actually costs them less than if you're in traditional Medicare. So how are you doing that?
Well, I would tell you, one of the reasons why, MA has grown from 9 million members toward 22 million members over the last decade or so is that the neat thing about MA is it's a consumer-based model. And the consumer decides, not the HR department, not the state government, the consumer decides. And that creates competitive pressures, and which ultimately creates price pressure, it creates innovation. And what I see is just, us and United going at it in a marketplace, or Aetna or whoever, we're going to find how do we win that customer over between service, between price, between the way we are providing our care models to them. Just how do we win them over? And so a lot of this competitiveness in the marketplace, I think, is driving some of the price down. But then subsequent to that, it's also the innovation around the care model. And if we can, prevent somebody from having a heart attack, God, that's wonderful for the individual. But that's wonderful for the healthcare system. It's wonderful for society. It's obviously a wonderful business model for us. So encouraging us to find the clinical models that do that, the technology, the analytics, the relationship with the providers are all examples where we can continue to lower the cost and at the same time increase the service level of it.
Yeah, because certainly even beneficiaries just heard some of those stories.
Exactly.
We have many of them just saying, I can get my eyeglasses, I can get a dental visit that's making a difference. People say, how do you do that? So just it is moving those dollars around in the right way to prevent those hospitalizations and high cost services.
And what it forces us to do is it forces us to be much more consumer oriented. The industry has been so institutional, working from the inside out as opposed to the outside in. And this ability to fight for the customer is such a great motivator for us as an organization to compete. And at the same time, it just is always focusing on what does the customer want. Right now, 28,000 of our 60,000, we call them associates, teammates, are paid on Net Promoter Score. So their bonus is determined, a portion of their bonus, but it's a material portion is paid on Net Promoter Score, and it's all around this idea we're going to win this customer over. And
maybe keep them for a really long time.
We do. They stay with us for an average of 7 to 10 years.
Yeah, that's amazing. Well, they can make a choice every year, so that's actually pretty impressive. We are talking a little bit about Humana, obviously, but it's also about sort of transforming the industry. It really is, and. Talking about just we're not quite at that tipping point, but Humana has been leading the way in working with public systems, actually, public payer, and understanding being responsive to that public payer at the same time as really finding a way to achieve these differences in outcomes. So talk a little bit more about that, just about the how you set the goals and move your own system and the providers you work with.
Well, there's a few principles when we think about innovation and what we're looking oriented. First, we believe that for you to be entrusted with someone's health, you have to have trust. And so the first thing is how can we continue to improve our service to our customers? So things, whether it's helping them with a question on a claim, to reducing pre-authorization, to reducing transfers, to finding the right person that has the right personality for an individual that has a need. And so if you're a chatty Cathy, we want to find a service rep that's a chatty Cathy. If someone's very direct and wants to get to the answer quickly, we want to find someone there. So this whole idea of how do we build empathy and personalization in the service side is an important part of our innovation. The second part is how do we continue to innovate to help the provider? How do we make their job easier? How can we how can we simplify it? How can we help them in being able to advance their business model, specifically around the ability to be more oriented to value-based payment models? And so just the way to advance that. And technology and information is an important part of that advancement, along with the human resource side. The third area, and there's a few people in the audience, we also believe in delivery model changes. There's a number of senior-based, fully focused clinics. We have about 270 that we have within the organization through various different means, whether we own them we partner with others. And those senior focus that are fully oriented to full risk, that are oriented to high retail-oriented customer service is a great example of innovation. It's not in a urgent care model. It's not in a professional office space. It is really, really convenient to the senior's needs. The other area is care delivery model evolving more and more to the home. Yes. The ability to invest in the home and have the home be a much more convenient area where, the providers can see a much more holistic aspect of that individual's life, and in addition, the ability to deliver it in a convenient way. And then technology. Technology in the area you were mentioning, a few devices, remote monitoring, telehealth, obviously, a great example of in the home. And then in addition, this ability to integrate the technology, to be able for a cardiologist to see what the primary care seeing what the cardiologist is, the ability to see what's happening in the home versus at the service area, where you have this holistic view of the customer, and then you can create an intervention based on personal needs, based on clinical needs, and based on preferences there. And all of those, I think, will make a great healthcare system a decade from now, but there's a lot of change happening in the healthcare system.
Care in the home is, I think, the new frontier here. Mm-hmm. You're obviously well positioned to do a lot about that. People want to stay in their homes. They love their homes. They also sometimes homes are risky, so getting a real sense of who the beneficiary is, who the patient is, and their needs. One more question, and then we'll open up to other audience questions. I do have a bunch more just in case they don't, but one more I'll ask about is really also something that Humana's done. That's really quite interesting. You call the bold goal, goal, and what's interesting is really understanding that the community. The neighborhood, some people say it's the zip code, where people live, really has such an enormous impact on their health care. And you've really taken the step of really getting into communities and really working with communities to be able to encourage healthy behaviors. Talk a little about
so there's a lot of history to the bold goal, and what we did in 2013 is we set out a beacon for the organization, and it was putting accountability to the organization of what we stand for. And so we set this goal back then to improve the health of the communities we serve by 20% by 2020 through making it easier for people to achieve their best health. And it was this idea of having a beacon with a quantitative measurement. And so we measure it by healthy days. And it's 4 questions about your mental and physical health. And it's really about the perception from the individual, not from the healthcare system. It's not about your BMI. It's not about, what your level of A1C, anything. It's about how do you feel? Mentally and physically. And if you can't answer that question that you feel well, then the healthcare system is failing you. That was just a very simple logic there. As we got into it, we realized that the large part of how people's health evolves is around their lifestyle. And we found that their communities have a large impact on their lifestyle, whether it's access to parks or access to food or access to social programs, you pick it, all have a really, really impact on that. And so we did a lot of work on that, and we came to the conclusion that the best thing for us, both in for our business model, but for the communities overall, is to support our communities. And so today, if you were to go on our website, we have a bold goal report every year that we put out. We measure our healthy days in that community and how are we performing against the community, and how have we helped the community and their continued passion of improving the health. And so it's been a wonderful opportunity for us to bring our organization together around a common cause. It's in the ability to hold us accountable for the advancement of what we're responsible for, and at the same time, it's also to help and have responsibility for how we bring the communities up.
Which is great. All right, before I continue, do we have some questions? Any from the audience? Oh, here we go. Ooh, we have a few.
Thank you.
Okay.
Thank God you didn't ask me to write a question. I read my writing.
I was going to say, this looks like people were pretty careful. We'll see. Maybe they screened out the ones I couldn't possibly read.
Yeah.
But it says, talking about integrated care and home-based model, can you describe the service delivery models that are being rolled out? We talked about this some, but I guess can you be a little more specific?
Sure. So just as a context a little bit, and a few years ago, I guess it was about a year and a half ago, we completed a transaction in purchasing Kindred Healthcare. We bought 40% with the call of having it up to 100% at the end of 4 years. And that included two parts to it. One was around the home health side, largest home health company in the country, and hospice. It was two sides there. And our whole goal is that we see home evolving in a few ways. We see home evolving first, moving from a therapy-based model, that reimbursement has always been oriented to therapy. And that's really where the rewards were, to more of a nursing model where you can take care of more expensive populations, COPD, CHF, diabetes, you know, pick the more chronic diseases. And so this evolvement is one in just around how you pay for it, and pay for outcomes, not for procedures or for the nurse, how many episodes you have. And so you see the organization today, we're in 6 states right now, moving that direction where we're paying on ER visits, reduction in ER visits, reduction of hospital stays, improvement in some of quality measures out there. So you see this payment model. The second reason we believe home is there is we believe the nurse or a social worker in the home has so much influence on an individual's care model. It has so much influence because it's convenient. They see the holistic aspect of how that individual is living, and they build a deeper relationship. So this Kindred has about 50,000 nurses that go in the home every day. And we looked at that as a distribution channel to be able to get into the home, to be able to have that, and to be able to both influence and treat care, but also to be able to understand what's going on in the home. So that was there. And then the last thing is we believe that with technology as telehealth, so assisted telehealth, is another, where you have a primary care doctor with a nurse going into the home that you can have a full-fledged visit, is another opportunity there. And then obviously the devices that you have. So we see this home model, payment model evolving. We see the ability for you to evolve who are the primary patients to be treated, from therapy to nursing. We see technology being the ability to facilitate a much more broader delivery model, and we see capturing deeper information to have better interventions down the road for the care.
Yeah, interesting, exciting. It seems sort of old-fashioned and very modern.
Exactly.
It kind of combines those things.
Exactly.
Absolutely. Okay, next question is, we have seen a lot of positive policy changes in Medicare Advantage in recent years. What can policymakers do to keep up this momentum? And what are specific policy changes that we should be advocating for?
Yeah, a few things. That's a
great question.
Yeah, great question. I think the evolution over the last number of years around social determinants has been a great evolution, and it's allowed the plans to be able to broaden their services, and broaden services that have a large impact. You know, in our work around social determinants, we find loneliness, we find food access, and we find financial challenges, especially for prescriptions, to be the biggest challenges in the areas of care. And so being able to offer those kind of services is we get really motivated with that. The VBID model is a very interesting model, and I find that to be an interesting, where you can start to cater your plans to the unique conditional needs and not try to make a broad generic plan. You can begin to start to narrow that down, and we have another number of plans that are coming out on VBID this year, and we're excited about that. So we thought those are really, really neat. I think continuing to push the information flow. Information flow and quality standards, because I know we're working with a few payers, and we're really at our lead of let's get definition of quality for the specialist more refined so that we're not driving each specialist, each payer, and the federal government have different quality standards. Let's narrow them down. Fewer is better than many. And then I think really let's take this interoperability on. I think the velocity of information and the flow of information has created so much innovation in other industries. Take the financial service industry. Over the last number of years, you've seen so much, over the last 30 years, you've seen so much innovation in that area as a result of velocity of information and the flow of information. I think for this industry to take another step, we have to take that on.
Yeah, it's not just across payers. Or just it's providers.
Providers, it's consumer, it's payer, it's everybody
I would
touches.
say those community organizations as well.
Yes, it is.
About that, which is an issue for them. So
Yes.
they have to gear up to
Yes.
do that kind of being interoperable, but not to have your provider know that what's going on when somebody visits you in the home is really a loss.
Exactly. Yeah. And we are working hard to bring those connection points. And it's not a standard anymore. With fire standards out there, it's not a standard. It's just pushing the industry to structurally change and take it on. And that's EMR companies, that's payers, that's providers. But it has to start with the consumer and empowering the consumer.
And then maybe connected to the consumer in a way, obviously, as well. So it is engaging consumers in a different way as well. But some consumers are much more technologically savvy than others, so I assume that you take that into account.
We do, but last year we did a study. We did a test, a pilot with the Blue Button work, and what we did is we went out to 10,000 members and asked them to if we could access their Medicare claims through the Blue Button initiative. And they said, I think 99% of them gave us the approval to do that. And what we did is we took that information and we came back and we said, this is the best Part D plan for you based on your information. What drugs are you using? What areas are important to you financially, because we'd ask them a few questions, and we'd come back and personalize it. As opposed to them trying to work through, and trying to figure it out, we came back to that. This year, we're going to do the same thing for the medical side. Is if you give us access to your claims, we will tell you based on providers, based on financial tolerance, based on conditions, what's the best models for you?
Well, that's great. I know that we've done some work with CMS to actually get them to be clearer with beneficiaries about their choices and to make it easier to make those decisions. And pushing almost easier on Part D. You can put your drugs in and figure out your plan.
More price.
A little more complicated with Medicare Advantage, but nonetheless, we're really interested in what more we could do to push them to make it easier for beneficiary, particularly one that, for example, already is in a managed care plan, to say which one's like that out there. Do I have to start from scratch here? How do I can begin to understand what might be the options for me? At least help me out here. So. Obviously, they're counselors and they're brokers and agents, but CMS and the plans have a real role in this in helping consumers navigate this the new choices that they have. And with the new flexibilities we offered, that'll even make it potentially more complicated for beneficiaries as well. Okay, this is interesting too. You've done some of this right, but you mentioned that social determinants is something that Humana is focusing on. Which ones are you going to add next, or what are you focusing on first? And I'm not sure you can answer this question. There's a little bit of a competitive model here, but by all means, give us some little line of sight into what you're doing.
I think as I mentioned, we believe loneliness and food access are really important. So what you see the organization doing over the last number of years, we've really oriented to the community and building the community infrastructure, so relationships with the food bank and some social programs. What you see us doing now is incorporating in our operating model of being able to access or understand who needs them, and then be able to work with the communities the communities support centers that we have to be able to get people to them. And so technology is an important part. You mentioned we have a few partnerships we're working on right now with organizations that actually are working with the community from a technology point of view to be able to bring these together. So this ability to put it in the operating model is and first understand who needs it. And so we are getting our providers to ask the questions. We're asking the questions on the on the interactions that we have with the customers to really understand it. And then when we know it, we then be able to bring it alive. And just as an example here, we had an individual that called our Part D service center, and she said, "Please stop sending my drugs." We inquired why, and she says, "Because I cannot afford them, and I will not be able to have food. So it's my drugs or my food." This individual said, put her on hold, called it was in Miami, called the Miami office and said, "Can we get the food bank to deliver food to this individual?" And we that day we actually had 20 days of food delivered to that individual. Mm-hmm. And she did not have to make the choice. And also we had social workers help her with her prescriptions. But that's an example where we have the operating model, we have the call-in, we have the mental mind of our associates and the computer systems to trigger it. And then we have the community-based resources to connect it to then solve the problem. And so it's as much about the benefit itself, but it's the ability to have that operating structure. And that's where you see the organization really, really pushing right now.
Very different than the way I think medical care used to be medical care,
That's right.
And now it's really saying you got to look more broadly at the needs. Our last question, which I get asked this question once in a while myself, so we'll be daring here. You can answer it or not. But where's Medicare? I'll soften it a little bit. But where's Medicare Advantage, fall in this whole conversation about Medicare for all?
Well, I'm biased as can be. As we were talking about at breakfast this morning, I've been on the provider side my whole career, and the only one of the reasons I came to Humana was Medicare Advantage. As I understood and studied Medicare Advantage, I really came to the conclusion that it is a model that has a lot of elements of success. Consumer decides. Guaranteed issuance, so everyone, it's not an insurance product. You're rewarded for taking care of the individuals that are in need the most, the sickest, and risk adjustments there. And in addition, it's a model that is also, you take full risk. So we just talked about social determinants. We talked about home. We don't care if we get paid for it, because we're not. We care that we are having an outcome of improving the quality and cost, because at the end of the day, we know that individual will stay with us for a long period of time, and we're going to help them. And so when I think about Medicare for all, and I think about some other discussions that are going politically, I look and say, it's about how do you find that ability to offer coverage where people are secure in being able to have their health care covered for them. And at the same time, it drives the right behaviors to be able to take care of the people that are in need, and to be able to be oriented to a more holistic view as just treating the symptoms. And so when I think about where Medicare Advantage is, if we do our work the right way, I can see Medicare Advantage being the payment model that is being used as you want to fill that need of where the employers, where people don't have an employer plan and they're not being covered by Medicaid. And I'm biased as hell, but I just think Medicare Advantage has all the elements to do that. And how can we take that and bring that alive in that population is what we should be talking about, because it has coverage and cost and quality incorporated in there.
Great ending. Let's thank our guests. Thank you, Bruce, very much.
Thank you.